Hello, my name is Moritz Dau. In my orthopedic practice, I'm specialized in sports medicine and interventional pain medicine. I will talk about the use of platelet-rich plasma, ACP, in spinal indications. The lumbar spine or lower back is a remarkably well-engineered structure of interconnecting bones, joints, nerves, ligaments and muscles, all working together to provide support, strength and flexibility. However, this complex structure also leaves the lower back susceptible to injury and pain. The lower back is especially stressed by our upright position and very likely to developing degeneration. The lower back is one of the most common disabling conditions worldwide. More than 80% of the Western population will develop lower back pain at least once during their lifetime. Of the people that consult their general practitioner for lower back pain, 1 year later, about 60% still report pain. The prevalence of chronic lower back pain is globally calculated to be about 9 to 10%. It is a common, long-lasting and disabling condition representing a huge economical burden on the individual and on the societies. There are various possible pain generators, of which osteoarthritis of the facet joints is one of the most frequent. So in the following, I focus on the treatment of the facet joints. Besides specific exercise programs to strengthen the surrounding muscles and increase trunk stability, targeted injection into the affected region are very common. Local anesthetics and steroids are frequently used with good results concerning the reduction of inflammation and pain and increased function. In many cases, though, the injections with local steroids need to be repeated after 2 to 4 months and then may lead to a weakening of the collagen structures of the injected area. There is a great amount of scientific proof for the use of ACP in joints, tendons and ligaments in many areas of the body, such as knee osteoarthritis or the tennis elbow, for example. In recent years, image-assisted platelet-rich plasma injections of the spine became more popular given initial promising results. Wu et al. Published a very promising trial in pain practice in 2017. It was a prospective randomized controlled trial with 46 patients, and he did a single injection of PRP compared to a local anesthetic and steroid. In his results, pain decrease was significantly in both groups. At 3 months, pain relief was significantly better in the PRP group. Functional scores improved more in the steroid group in short term, and opposite occurred in the long-term period with the PRP group. Patient satisfaction in the PRP group increased over time to 81% after 6 months versus 50% in the steroid group. I started to inject facet joints in 2007 and began using ACP in 2010 as an alternative to the common injection with a local anesthetic and a steroid. I have now treated more than 10,000 facet joints successfully. In many of my patients, ACP showed very good results, and in all these cases using ACP, there were no severe associated complications. The treatment of lumbar back pain is very patient-specific and should follow a multimodal concept aligned to the exact diagnosis and circumstances. If necessary, this multimodal concept includes interventional techniques such as the application of ACP. During the initial visit of a patient in my practice, I take the history of the complaints, including duration, detailed symptoms and previous treatments, examine the back with multiple tests, and if necessary, arrange imaging such as X-ray or MRI. According to the diagnosis, an individual multimodal therapy program is established. If ACP is part of the treatment, 3 appointments in about a weekly interval are arranged. ACP is applied guided by either ultrasound or X-ray. The patient is informed about the procedure and about a possible initial increase of pain for a few days. In the lumbar spine, there are typical pain generators, and of course the facet joint is one of the most important of them. In most cases, the level L4-5 and L5-S1 is concerned with activated osteoarthritis of the facet joints. Besides that, we should not forget the ligaments, where ACP is used very successfully and is very often the treatment of choice. In most cases, the iliolumbar ligament is affected and can be treated as well. Also, nerve root injections or injections into the sacroiliac joint can be performed using ACP. A manual examination will help to verify the correct diagnosis and affected segment before the injection. In a certified treatment room, equipped with the appropriate fluoroscopy imaging technology, the patient is positioned prone on the table. We want to select the thinnest needle possible, which is, of course, possible with thin patients. As a rule, I use the 21 gauge needle, shown here with a length of 8 centimeters. This is used for most part of the patient and is sufficient. With a more heavy patient, we have to use longer needles. Here we have the 20 gauge needle, which should reach most facet joints. A further advantage is that the bevel can still be used for navigation. This means we can bend the needle slightly here at the top in the direction of the bevel. As such, when navigating, I can still use the bevel at the bottom and move the tip of the needle either in this or that direction. Of course, a far more elegant solution is to use a needle like this one with the mandrel, as you don't have to bend or change anything. It is easy to remember that the small seam on the top is always on the side with the bevel. In terms of sterility and sterile working, there are various options and methods for applying the ACP. There is either the maximum version, where everything is covered in sterile drapes and you have everything passed to you by the surgical nurse. Or alternatively, there's the no-touch technique, where you even go without gloves and disinfect the hands. You only then need to wear a mask and apply the ACP properly. A contrast agent can be used to verify the intra-articular position of the application. I generally use one ACP syringe for 2 joints, as we need around 1 milliliter for the joint itself and 1 milliliter for the area around the joint. A little less is needed in the cervical spine. I can now set up the right position here, the lumbosacral junction, as mostly the case. I now take my first image. Here the lumbosacral junction can be seen exactly in the image. I have hit the L4-5 orthograde plane. This is evident by the fact that the base plate of L4 and the cover plate of L5 are shown as a line, and I can see the intervertebral disc space clearly. I infiltrate this plane precisely by swiveling to the side to locate the facet joint. If I also wish to infiltrate plane L5S1, I have to take the lordosis into account and swivel the C-arm accordingly. I can take an image here to get an orthograde view of plane L4-5, and I can clearly see the facet joint on the right of the image, which I can locate through lateral inclination. The correct position of the needle or the correct puncture site can be found by either using the laser or by locating the site using the needle and then puncturing the skin here. As far as possible, the needle should appear in an orthograde position with the tip above the joint cavity. I can then push the needle forward with the tip until contact with the bone is obtained. I can take a number of images here. I now have to go somewhat toward lateral to reach the joint cavity, and then once again I'm correctly in the joint cavity with the needle or precisely on the right path. Once I'm in the joint, I can apply my contrast agent. I can feel the joint cavity here and apply my contrast agent as required. Here we can see the upper and lower recess and distribution of the contrast agent along the joint cavity. I can then apply the ACP accordingly. During application, I ensure that I inject around 1 to 2 milliliter into the joint and then pull the needle up slightly and apply 1 to 1.5 milliliter around the joint, and then you have completed the application of ACP as performed by us. We do the same again. I can mark the correct position of the needle using the laser. The skin is punctured here. Again, the needle should be positioned as orthograde as possible. Ideally, it should look like a dot. Then I push further along the path and keep an eye on the facet joint. Correct position again until the joint can be felt directly. I can sense an arthrotic joint here, and now I'm in the joint. I have a syringe here which allows for a little more pressure. I can read off my milliliters here and apply a little pressure here below. I apply 1 to 2 milliliters until the capsule is full. Filling off the capsule is a pain stimulus for the patient. I can now pull out the needle a little and still infiltrate the remaining 1.5 milliliters, so a part lands around the capsule. I now can remove the syringe and pull out the needle, and facet joint infiltration is complete. As in most cases, all 4 facet joints L4-5 and L5-S1 are concerned, and we have an activated osteoarthritis within all these 4 joints. So I will show now a brief film about how to inject in all these 4 facet joints at the same time. The X-ray shows an image of each facet joint, first of the facet joint without the contrast, and then after a contrast agent has been applied, so that the correct distribution of the contrast can be seen.